good afternoon, I guess, everyone. Thanks for joining on. And yeah, I'm going to give you this talk on prostate artery embolization. And I think, you told me you guys are experienced with doing fibroid embolizations and with doing chemoembolizations, TACE procedures. So like you said, it's a very conceptually similar procedure, similar to fibroid embolization. In both cases, it's like like a reproductive tract kind of hormone induced overgrowth of normal tissue. So in females it's the uterus, and males it's the prostate. um and in both cases, like, both problems are they attempt to manage medically by kind of blocking the hormonal influence on the tissue and trying to get it to shrink. And then oftentimes that's not really adequate. And so then we go to procedural. And lots of times in women, I don't know, what practice patterns are like over in Tanzania. Um, I suspect similar to US in that lots of times women will get hysterectomies where they, just cut the whole thing out. Likewise, in men, they'll undergo surgery. There's a lot of different surgical options for an enlarged, benign prostate. But lots of times both are very invasive. And as interventional radiologists, of course, you guys know we can offer much less invasive but still very effective procedures. And so embolization is one of them. And again, it's a similar concept, doing pelvic angiography, getting into the arteries on both sides and putting an embolic agent in. So just keep all those similarities in mind as we go through this. And I have a lot of information in this talk, but I'll try and focus on the stuff that's probably more relevant and more appropriate. And at any point, just, stop and interrupt and ask questions as we go. Okay. Maybe I can send this to you afterwards, and it'd be great to set up something with the urologist. I don't know, what your relationship is with them and how easy they are to kind of track down, but I could give the same, or similar talk with a different focus to the urologist, if that would be helpful. So let me share my screen now.
Yeah, that should be definitely doable. So maybe who can we put in charge of that? I don't know, maybe Himidi or Monabas, if one of the seniors in Tanzania, if you can start reaching out to urology and making sure that we can set up like a Grand Browns lecture for Raj when he's there in July. Can you guys
Or
do that?
even earlier now on Zoom, and that might facilitate
Or something on, yeah,
getting patients.
maybe something on Zoom,
Yeah.
but otherwise also what we can do is like for your first week while you're there, like what may happen is that they can sort of line up a lot of the clinic visits for the first week, and then you do most of the procedures in the second week.
Yeah.
But RDC have some definite ones sort of lined up beforehand, so that you already have some procedures for the first week. But then those that need a little further workup, you may see them in clinic during the first week and then do the embolization next week.
Yep. Okay, great. Can anyone see my screen? Is it visible? My presentation?
Yes, we can.
Okay, great. Okay, I have no disclosures. Is my that if you want, write down my email address there. That's my work email address, and I think I have it at the end as well. Just so you can get in touch with me. WhatsApp works as well. Okay, so I'm going to give you an overview, like I said, of BPH and how it works, some kind of treatment options. We'll talk about the concept behind PAE procedures, and then I'll spend a lot of time going through kind of some typical cases. Definition, BPH stands for benign prostatic hyperplasia. That, of course, is a histopathologic diagnosis. It can cause bladder outlet obstruction when it gets bad, so we call that BOO. And then when it's causing bladder outlet obstruction, it's called BPO, but we all use BPH and everyone knows what that is. I'm not sure what the demographics are like in Tanzania or in the surrounding regions, but at least in the United States, it's found in even in men in their 30s. As men get older, it gets more and more common. So in men in their 70s and 80s, it's, the large majority of patients have some degree of this problem. By itself, it doesn't kill you or hurt you, but has major impacts on morbidity, quality of life, and healthcare costs for, most of elderly men. It can lead to urinary tract infections, and then when it gets really bad, it can back up the kidneys and then cause failure. That's very rare, but we see it every now and then. And then As the problem gets worse and worse, it can lead to urinary retention. So then a patient has to have an indwelling urinary catheter the whole time. That can be miserable. It can lead to urinary tract infections. It can cause or aggravate bleeding from the prostate. And also, it can be very expensive and very challenging for people without resources to manage. And there's just a nice schematic diagram, a sagittal view of the male genitalia, the GU system, and it's just how the prostate sits like a donut around the urethra at the base of the bladder, and how when it's normal size, urine can flow through no problem. However, once it gets very bigger, it gets pinched. So it's really not so much the gland of the size, but how it gets pinched off in the center, how it pinches the urethra, and then prevents urine flow, normal urine flow. So to keep in mind, there's not necessarily a big correlation between severity and the gland size. Some are going to have the biggest gland in the world, but if the urethra is open in the center, they can urinate fine and it's not a big deal. Whereas sometimes you can do an embolization procedure and get really, really good shrinkage of the gland when you measure it, with a CAT scan or a CT scan or MRI. But then they may not get such a great improvement if they don't get a good, treatment around the urethra. And it's really all about the flow and the symptoms, not just gland size at all. So now, how do we diagnose patients? So for patients, what we call LUTS, lower urinary tract symptoms, we use this International Prostate Symptom Score, the IPSS, which I mean, it's used pretty much throughout the entire world. And I don't know if you guys recognize this or have seen it, or if indeed it is being used in your area. I suspect that it is. And so what it is, it's a basic questionnaire that patients fill out. It goes through kind of 7 kind of classic symptoms of urinary obstruction, urine flow obstruction, and they ask the patient to rate how bad the problem is. Each question, they give a score of 0 to 5. 0 is there's no problem. 5 is their problem is the worst it could be. So we have incomplete emptying, frequency, so having to go, very often, less than 2 hours between urinations. Intermittency, where the urinary stream stops and starts. Urgency, when a patient just has to run to the bathroom and sometimes leaks on the way. The most obvious one is the weak stream, when they feel like they have to, the urine is very slow. Straining is when they actually have to push to get the urine out. And then nocturia is the times a patient gets up at night to urinate. If a score is 0 to 7, we say the patient is mild. And actually, most patients will, I mean, even teenagers and 20-something-year-olds, no one has perfect 0 score. Just normal people, like I said, young people will often have scores up to 7. So don't think of, that is really abnormal. When a patient gets from 8 to 19 in the moderate range, then they need to really consider treatment. Usually these days, people use a threshold of 10 to initiate even like some kind of surgical or procedural treatment. So when they are even not so bad, they'll start medications. And then, of course, once they're severe, 20 to 35, they should definitely be having something done. The quality of life is just another score people just circle just to describe how badly they feel about their situation. When a patient is actually in frank retention with a urinary catheter in, this score doesn't apply because they're not urinating in themselves anymore. It's just coming through the catheter. Oops, I just went through all that. We also ask them to kind of fill out what their erectile function is. There are many different metrics for that. In the US, we use something called the SHIM or IEFF. Not so important, but just nice to know what their baseline is. Then more objective. So this is subjective, like what a patient kind of feels and how they themselves rate the problem. We'll also measure urine flow rates, or a PVR. That's the post-void residual. That for me is one of the most important numbers. We'll of course measure the gland volume. Commonly, we have patients undergo a cystoscopy, where the urologist put a scope up and take a look at the gland just to make sure, for example, if they're bleeding, if there's not some other cause for bleeding, like a bladder cancer or some kind of trauma or a stone. They'll also kind of size up the gland a bit, not so much the overall volume, but kind of the length, how tall it is, from the entrance of the urethra down to its very, lower extent. And then sometimes we'll get what's called a urodynamic study. This device is something that measures urine flow. It's very cheap and easy. It's probably, readily available throughout most of the world. It's basically the patient just urinates into this funnel, and then there's basically like a little scale there, and it basically measures pressure over time. And it prints out a little piece of paper that just shows you that little graph, and then you can see what their urine flow rate is. This is a urodynamic study. This is very, very rarely done. It's usually for problem solving when a patient has some kind of perhaps a neurological disorder like Parkinson's or like a spinal cord injury, and we're not sure if the problem is bladder function, a neurological problem, or just regular obstruction. But as you can guess, it's invasive. A catheter is put in the penis, into the bladder. Another, like a pressure transducer device, is put in the rectum, and you have patient perform all these maneuvers. So it's really hard to do, and very invasive. So that's very
Raj,
yeah.
what is like your minimum workup? I mean, if a urologist says, okay, I have a guy here with very typical symptoms, for several years.
Yeah, basically, if you guys are using this score, just that score sheet, and then post-void residual, which is easily measured with an ultrasound. It's nice to know the gland volume, but again, it's not critical because, like I said, the volume is doesn't really correlate with symptoms. It's nice. I know bigger glands will usually mean bigger arteries, and just from a procedure point of view, I come in to the procedure knowing what to expect a little bit more. So that's really it. I think if they probably should get a cystoscopy, but if they haven't had one done, that's not a deal breaker. So just the score and a post-void residual are really easy to do. And we can do the post-void residual ourselves. We're radiologists, so I do it very often where I just, you just have the patient, you measure their bladder, see what's in them before they urinate. You have them come to clinic with a full bladder if possible. Then you have them go urinate, and then they come back, and you just, put the ultrasound scanner on their bladder and measure the volume. Thanks for asking that. Okay, so medical management. I imagine the medications are obviously the brand names may be different in Tanzania, but the overall medications are probably very similar or the same. Typically, urologists will start with these what we call alpha-adrenergic antagonists. So tamsulosin or alfuzosin are the most commonly ones prescribed in the United States. They basically relax the muscle around the prostate and the urethra and the bladder neck to help things open up and flow better. Then lots of times people will use these 5-alpha reductase inhibitors. So finasteride and dutasteride are the common ones. And these are the ones that, like I mentioned before, kind of try to blockade the testosterone influence on the tissue of the prostate to help try and decrease its size to reverse that endocrinologic influence. These work well for the people who have more mild symptoms. They'll improve that symptom score by 20 to 40%. They'll improve urine flow rates. But a lot of patients, probably more than 10%, experience these side effects. So impotence, decreased libido, and because of the 5-alpha reductase inhibitor, that blockage of testosterone. And then for the tamsulosin patients, the alpha-adrenergic antagonist patients, they'll feel dizziness and hypotension sometimes for real. And so a lot of patients will end up stopping these medications because of those problems. I don't know if this medication is commonly prescribed in Tanzania, but Cialis or tadalafil is a phosphodiesterase inhibitor, which also is generally used to help with erectile dysfunction, but was also found to help with relieving urinary obstruction. So when the symptoms are, not when they're more severe than medications can handle, then it's time to talk about surgery. Probably throughout the world, as much in the US and probably in Tanzania, the most common procedure for this is called a TURP, T-U-R-P. It's the transurethral resection of prostate. It's generally thought of as the gold standard for surgical therapy. Basically, they put a metal scope up the penile urethra, and then they, with cautery, they kind of scoop out pieces of the prostate and try and open up the channel. It's generally for glands that are up to 80 to 110, 120 milliliters in size. People, could do it for smaller glands. That's not bad. But once the glands are beyond that size, the TURP is really it's too hard to do. It's too challenging, and it's hard to do safely. And so then those patients have far fewer options. And when a gland is less than 80, there are a lot of different options, and those really depend on the region and what the urologists like to offer. I suspect, and I don't know if you guys know, that TURP is probably going to be the most common in your area. Does anyone know what urologists do for BPH surgically? Well, you should ask them, and because that'll also in general for your knowledge, but also help us to kind of plan what we want to do or how to approach the urologist about these patients, and how to kind of win some referrals overall. So
Yeah, but
anyway,
Himidi, for instance, like I mean, TURP is available, right? At Mambili,
Sorry?
do you know? TURP, is that available?
It is.
It is. All right. So that's probably the standard that they do.
yeah. So it works well. It reduces the symptom score by up to 70%. So if someone has a score of, say 20, they'll typically come out with, something back down to the mild range. And it works great with, improving flow. However, obviously when you're cutting out tissue, it's invasive, it can be bloody or painful. It requires some level of anesthesia. Patients will usually get admitted to the hospital. They'll have a catheter in for at least a few days. And like I said, it's not good for large glands. Reoperation rates are about 15% at 5 years. And for those men who have preserved erectile function, sexual function, there's a good chance it'll knock out the nerves and cause problems with erections. And then there are much smaller, much more rare but more severe complications like bladder perforation, severe bleeding, urinary infections that are much less common but much more severe. And finally, there are risks of incontinence if they just damage the muscles, the sphincter muscles. And then the reverse of that problem, bladder neck contracture, so scarring. And something called TURP syndrome, where so in order to perform the cautery, they have to be infusing with a non-ionic irrigant the entire time. And as they cut away the tissue, they're leaving kind of raw, exposed kind of tissue open, and then patients can absorb the fluid through through kind of that raw surface. And then they can actually have pretty profound electrolyte disturbances, like hyponatremia, and have to be admitted for that. And so that's one of the reasons why urologists limit the gland size to, depending on the urologist and their experience, to say 110 milliliters, because if they have to be in there for too much longer, then the risk of TURP syndrome goes up. Like I said, there are lots of other possible less invasive surgical options, which I won't go through here much because, again, these vary by the region. However, and this is something for very small glands, but and my guess is that in Tanzania, probably for those patients with the really large glands above 110 milliliters, that they're probably doing what's called a simple prostatectomy, where they cut the patient open and just scoop the whole thing out. Sometimes, I mean, it's pretty barbaric. Sometimes just do it with their hand. They'll scoop in and reach blindly and just kind of scoop stuff out. I don't know, again, what the surgical kind of capacities are there. Like in the United States, that'll commonly be done with a laparoscopic approach, kind of a robotic prostatectomy. But still in the US and probably most places in the world, lots of places will do the open, they'll just cut the patient open and scoop it out. A very invasive, very bloody surgery, should not be done anymore. I don't think, now that embolization is available, and it can be really hard for elderly patients to undergo such a major surgery. Now, just talking about blood in the urine, so gross hematuria. So the patients in urinary retention and the patients with hematuria will be the two most likely kind of groups of patients that we can help with, at least early on, that the urologist may be more willing to refer to us. So the bleeding from the prostate can be severe. And we've had patients, come in, they're admitted to the intensive care units. They need blood transfusions. So it's not just, oh, the urine's a little bloody, but it can be very, very, severe and require lots of resources. And lots of times then patients have to have catheters in. Sometimes the catheter has to stay in, but even with the bleeding, the clots can cause the catheters to plug up, and then they need to get them urgently exchanged. Sometimes they'll try and prescribe finasteride to shut this down. That can take weeks or months, you know, to be effective, and oftentimes it's not effective anyway. And like I said, it can require, you know, pretty invasive procedures to get it fixed. So obviously we're here to talk about what IR can do for these patients. Those who fail medical management, they're not surgical candidates because of their illnesses or because they have very large glands. And then there are lots of men out there, once they hear about their options, they want something less invasive with lower risks, especially those who have preserved sexual function and they don't want to risk losing that. And in general, for bleeding, embolization, of course, makes sense, just going in and, you know, cutting off blood flow to the vessels that are bleeding. So prostate embolization, PAE, was first reported in humans in the year 2000. And since then, a lot of data have been generated, a lot of work has been done over the past 25 years. About a year and a half ago, it finally got approved by the American Urological Association, which was a huge roadblock to practicing this procedure in the United States. I won't spend a lot of time on this. You guys probably know pelvic arterial anatomy well enough already, but just a schematic diagram here. Like we were discussing, this is also where there are similarities with the fibroid embolization procedure, but there are also huge differences. Usually with fibroid embolizations, the arteries and the uterine arteries are very, very big, very easy to get into, really hard to mistake. However, with men with enlarged prostates, so now these are elderly men that will have perhaps more atherosclerotic disease. The vessels feeding the prostate, even when they're very big, are generally pretty small. And like I said, for glands that are on the small end of the scale, they'll commonly have small arteries, and so they can be challenging to get into, to find, and then to get into with a microcatheter. Lots of variations in the anatomy are also present, and I would say almost the norm. And then there are lots of anastomoses where arteries feeding the prostate will connect to those arteries that feed the bladder or the rectum or the penis. And while I'm sure these anastomoses exist in female patients who are getting fibroid embolizations, somehow we never really see them. And the beads are large enough typically that we use, at least in the United States, to really prevent complications. So these problems are very, very rarely even thought about in fibroid embolizations. However, in prostate embolization, the non-target embolization risk is much higher, and the risk for damage is much higher. And so we have to pay much more attention to that. Typically, the prostatic artery is a continuation of what we call the inferior vesical artery, which supplies the seminal vesicles, the trigone of the bladder, you know, the base of the bladder, and the prostate. Its origin, you know, where it comes off of, there's usually 4 different categories of origins, which we can go through, you know, when I'm there. It's a little hard to just talk about on diagrams. It's usually better to go through with cases. But that's just a quick look at the anatomy. How is this done? So you can go with radial
Raj,
access. Yes.
one question. This,
Sure.
since we're speaking of particles, we typically don't have embospheres in Tanzania. It's mostly PVA. Would you okay to do it with PVA, or should we try to get embospheres or something else?
I've never used PVA, and there are not a lot of data on PVA, but I mean, obviously it's just a matter of kind of getting used to it. If there are some kind of, you know, like more like beads or embozines or these different brands of beads, I think that the data are better for those, and we might get better outcomes, and of course it'll be more familiar. But you know, whatever works.
Good. All right. So ideally embospheres or embozines, but if not, then PVA.
Yeah.
Good.
So femoral or radial access. What do you guys do there mostly? Do you do radial access at all?
Mostly femoral.
Okay. Yeah, me too. I like femoral a lot better than radial, but radial is always an option, or typically an option. We'll just put a small sheath in, and then we just put in a 5 French catheter. I like to use, I don't know if you guys are familiar with the names that we use, but something called like a SOS catheter, SOS. It's this one here with this hook on it in the picture. And then there are all sorts of fancy microcatheters that are available on the market depending on where you are. The Swift Ninja is a steerable microcatheter, but I don't really use that. It's just it's fun to get out and use sometimes. These are the embospheres, the vials, different sized beads. I like to use the Sniper a lot, which is a microcatheter with a balloon tip, but it's very, very expensive. I've been using actually glue these days for prostates. I started using glue about 3 or 4 months ago. I don't know if you guys ever have glue available. Not something I would consider. It's very, I guess, a new thing, and there's only a few places that really use it. So it's still kind of, very new. Beads would be the standard, but glue is really cool. Sometimes we'll use coils to kind of plug up the collateral so we don't get the embolic agent into the wrong arteries. And this is just a paper I wrote about patient selection, which we won't really bother with. We talked about the clinical evaluation, what we get done. Lots of people will get CT angiograms or MRIs beforehand to map out the vessels and get the gland size. I don't think those are really necessarily important. I don't bother with them for the most part. And we talked about kind of like which patients, they're very, basically the one take home message here, there are very few patients that are not good candidates for embolization as long as they have, true BPH. So people with urinary retention, with catheters in, again, people with that gross hematuria from their prostate, and people with kind of moderate range symptoms also. So as long as they don't have an active urinary infection, severe renal insufficiency where they can't get the contrast, or some, coagulopathy that really makes you scared to get into the arteries, really almost anyone will do quite well with embolization.
Do you
So
have
like I
any
said,
cutoff for if someone's had a catheter for years, where you then say,
no,
okay,
I mean, then I might suspect that the bladder is not working well anymore. And so that's when you might get the urodynamic study to really do a good evaluation of bladder function. Because if the bladder is just stretched and big and not going to work anymore, then it's, it's not worth doing. But in the setting of not having a urodynamic study, it's hard to figure that out. And so what I tell people is that the procedure is so easy to do and low risk that even if we don't think there's much chance of success, usually it's worth a try anyway.
worth a try, and just kind of make clear that's a little bit harder to predict.
Yeah.
Okay.
So it's an outpatient procedure, typically, it'll usually last 2 hours, or nowadays, people do it hour and a half. I do mine usually about an hour and a half. Pain is very minimal. We just give a little bit of
Gary?
Yes,
Sorry, Professor Thomas has a question.
sure.
I have a question. There's patients who have BPH and have recurrent prostatitis, so eventually they call them chronic prostatitis. So
Yeah.
how is the response?
I don't know. There are a lot of data on actually like kind of the response of inflammation as a result and how it responds to embolization. I think usually if it's a result of a infection, a recurrent infection, that's probably because they're not emptying their bladder well and they have chronic urinary retention. And so helping them with that will, I think, often be very helpful for the prostatitis if it's infectious. If it's not, I mean, I think when you embolize them and you kind of shrink the gland down, I think people do believe that does help with the non-infectious prostatitis, but I don't think they're very good data yet to really kind of, demonstrate that.
Okay, thank you.
Yep. So the pain is minimal for the procedure. We just give some fentanyl and Versed typically, so moderate sedation. We usually give a medication called Toradol, ketorolac. It's like an IV version of ibuprofen, which helps with the inflammation afterwards. Like I said, femoral or radial access. I don't know if your angiography suites can do cone beam CT. I don't really bother with that. It's very, very rare that I do that. So if we don't have that, I wouldn't consider that a problem. Like I said,
You can do.
oh,
They
good.
have
Okay.
probably.
Oh, excellent. Okay. So maybe we'll do that a lot anyway, even if it's not necessarily like required.
Yeah, I mean, I'll say for me, having recently, only very recently started to do this myself, that it's very good for peace of mind. And I'm sure that at some point after years, that you just know. But for me, even now, I usually always do it, and it's just gives me peace of mind. And I've had it a few times that I was then, oh, there's actually like a connection to the middle rectal that I really didn't pick up.
Yeah.
So yeah.
Yep. So then, like we said, we put in, an embolic agent. Embospheres are common, but whatever we have there, until we get stasis in the vessels. Sometimes we'll coil collaterals. We send patients home the same day after the procedure. It's nice to follow up with them. Usually the gland will shrink over a 3-month period. Most of the symptom improvement will happen by the end of the first month, but all the way through 3 months, they'll notice improvement. So checking in with them, and they'll just fill out that symptom score every time. And every time we'll measure the post-void residual to see how they're doing with those two parameters, because those are the parameters that are important, right? Like how well do they feel and how well are they empty. For those patients who have catheters in, we usually give them a 1-month period of shrinkage before we try and take the catheter out. That's called a voiding trial. And I'll skip over this. So, and I'll go through 1 or 2 cases. So I'll skip over these images for now, but these are just, CTA and angiographic images. Sorry, cone beam and angiographic images. Okay, so case 1, 70-year-old guy with urinary retention, severe BPH. He did not, the medications did not help. He had a Foley and a catheter in for 16 months. He had urinary infections, blood in the urine. Like I said, the scores don't really apply for retention patients. He had a very large gland, 245 milliliters. This is the pelvic angio. This is the balloon for the catheter. It should be much lower down, at the bottom of the pubic symphysis, but his gland is so big that the catheter is riding high. You can tell these vessels are tortuous, but not particularly challenging to work with. So we get first into the left side. This is a left anterior oblique injection of the internal iliac artery. And that's the balloon for the Foley. This is the superior vesical artery feeding the bladder. That is his internal pudendal artery. That's the inferior gluteal artery. This is the middle rectal artery. We don't want to get into that. That was the inferior vesical artery, which then becomes, or is named the prostatic artery, which is where we wanted to get into. He did have an obturator. He has what we call corona mortis. His obturator artery was coming off the external iliac artery. So we got selected with a microcatheter. So any, I use 2.2 French microcatheters. People use smaller. Probably 2.4 will be fine. That's what I used for a few years before smaller catheters became available. So if you guys have like 2.0 to 2.4 French microcatheters, that should be good. We get in, those the branches feeding the left half of the prostate. This is an axial image of a cone beam CT where we're injecting dye into the left half of the prostate. You can see things look good. So we embolized. Then we move to the right side, right anterior oblique projection, injection of the internal iliac artery. That's where the Foley balloon was. Again, superior vesical artery, internal pudendal artery, inferior gluteal artery. That's the obturator artery here. And then this is the inferior vesical artery, which was feeding the prostate. And there was that other branch there, which was probably the middle rectal artery. So we get in, we do an angiography from the frontal view, and you can see that's the inferior vesical artery again. And we do a cone beam CT, and this is like a case Fabian was talking about. We get nice, so we've embolized the left gland, so you see some staining there. Now we're looking at the right gland. You can see, blood flow in it, but you also see some blood flow back here out of the prostate going around the rectum. And we check it out, and it turns out there's a connection to the middle rectal. So we don't want beads to go to the rectum, particles, I should say. So that's a branch off the inferior mesenteric artery. So we got through and put a little coil in there, plugged up the door. So we're not devascularizing the rectum per se. We're just closing off the pathway from one vessel to another. So the beads, the particles stay where we want them to go. So we embolized him. On that side, he did great. At 12 months, the symptom score was down to 3, which is very, very low. Quality of life score is 0, which is the lowest. So he was very, very happy. His post-void residual was only 80 milliliters, compared to like a liter before if he didn't have a catheter in. His gland shrunk by about 25%. And you can see that's a sagittal view. You can even see a little channel that opened up in his prostate there. And then he got his first erection 12 years. Lots of times patients will actually have an improvement, not lots of times, some will get improvement in their sexual function. And so this is just a paper we published. And these data are a little hard to go through in short time here, but basically, look on the graph to the right is the more appropriate graph to look at. This is the bottom scale is time, and the vertical scale is the patients who are in retention initially are red, self-catheterizing are orange, and then yellow are the patients who are voiding normally. And you can see it at time 0, everyone has catheters in because that's the group we're studying here, of course. But as time goes out, we're usually able to get the catheter out of patients, 75, 80% of the time, and then all the way out to 4 years, so 48 months, doing quite well. So it works very well for patients with retention. These are their symptom scores. Like I said, mild is 7 and below. So basically after 6 months and beyond, many of these patients have nice low symptom scores as well. So this is, let's see, we have time for maybe 1 or 2 more cases. This is a more typical case. A guy with severe lower urinary tract symptoms, so a high IPSS score. He does not have a catheter in. The medications did not work well for him. His score was 23, so he's in the severe range. Also has a very high quality of life score, so he's unhappy. His post-void residuals elevated. It should be 0, right? And people who are urinating well, it should be 0. Anything less than 50, people won't really pay attention to. Anything less than 100, 150 is okay. Beyond that, it's pretty bad. It's a sign that the bladder is really struggling. So his residual was high. His gland was big, 187. And he had that Euroflow study where he urinates in that device, and we measured it, and he had a clearly obstructive pattern. He was not a candidate for surgery because his gland was so big. He'd been having urinary tract infections. So here we are. Our catheter is in the left anterior oblique position, and we're injecting the internal iliac artery. And you can see there's the inferior vesicle, the prostatic artery, and the vessels flowing to the left half of the prostate. Just a more selective view of that. And you can see where the gland is relative to the bladder, which is filled with contrast from the urine. And there's a nice corollary cone beam CT picture there. There's a lot of reflux. We did a brisk injection, so you see reflux into arteries feeding other structures there. But that was not from collaterals. That just was because we did a very, very brisk run. So there's contrast kind of going everywhere. We ended up putting some coils in, and then to block collaterals, and then we embolized him. And then we went to the right side, and you can see here now we've selected the right prostatic artery. There's the flow to the prostate. You can see the bladder full of contrast, and just a more selective digital subtraction angiogram of the same. And there's the cone beam CT. Now you see the staining having embolized the left side first, and now on the right side you can see that we're going to have a good angiographic result there. And so 3 months, his symptom score went from 23 down to 6. His quality of life score went from 5 to 0. So great improvements symptomatically. His post-void residual was, like I said, excellent, like next to nothing now, down to 10. His gland actually shrank to about half the size. Usually we expect the gland to shrink by about 1/3. So this was very kind of on the one end of the scale. So look at these CT scans there. You can see his gland shrank a lot. And he was actually annoyed because the penis, the shaft of his penis actually seemed to shift in a little bit because the gland was no longer pushing out. You can see there the corpora of his penis. So he was complaining that he thought his penis got smaller, but in reality, it just his gland got smaller and his anatomy shifted. So now, again, this is just data we published on patients with lower urinary tract symptoms and their improvement in the symptom score. So people come in, average is 22.5. Or 0.4, I should say. And then after embolization, 1, 3, 6, 12, 24 months, you see a very nice preserved reduction in their symptom score down to more or less, 6, 7. So in that mild range for the most part. And then these, very similar to that graph I showed you before, just look at this side, because these are the patients with large glands. And so red is people with severe symptoms, yellow is people with moderate symptoms, and green people with mild symptoms. So in the beginning, we're treating patients that about 2/3 of them have severe symptoms, 1/3 are in the moderate range. And after we treat them, you can see a huge number of patients, probably about 60% or more, go into the mild range. The remaining are in the moderate, very, very few that persist, who have, not a good result and have persistent severe symptoms. So works really, really well for lower urinary tract symptom patients. And then we looked at reduction in gland volume and the post-void residual. So you can see the post-void residual went from like 175 down to like, 80s, 90s maybe. So about half reduction in that. And then, like I said, the gland volume, we started out at 120, and we saw a pretty nice reduction in that as well. Okay, that slide is not worth talking about. It's a lot of data that we don't need to go through. So then this was a case, a guy with severe gross hematuria. So this is the third major indication, and I see we're running out of time, so I'll just go through this very quickly. Basically, he had really bad atherosclerotic disease. We didn't see any arteries feeding the prostate in this left internal artery angio. So we went to the right side, and lo and behold, we found this tiny vessel that fed both the left gland and the right gland. Now notice he has a collateral going down towards the penis there. So, sorry, that's how it worked. So we got in, we embolized his left gland first, and then the right gland backfilled. And so it was very nice to treat both sides from one catheter position, which is very, very rare. And again, just our data on this, again, look at the graph on the right. So patients with severe, like episodic gross, like large volume hematuria are orange. People with severe hematuria in the hospital getting transfusions and so on are red. And patients with clear urine are yellow. And you can see again, how successful this procedure is with treating patients with gross hematuria. The orange patients are usually patients who remained on anticoagulation, like people like stroke patients or cardiac patients. So it's very, very successful. We say well over 95% of patients generally will stop bleeding. And this is just a lot of subtle information that we need not go through today. Overall, about 7 out of 8 patients have a great result with this procedure when they have lower urinary tract symptoms with a 2/3 reduction in their scores. Like I said, about 75% of patients are able to get their catheters out when they're in retention and go back to normal urination, or reasonable, I won't say normal urination. About 60% of patients will be able to stop those BPH medications. Gland volume shrink by about a third, and like I said, 95% or better patients will do well with bleeding. These are complication rates, which I won't go through line by line, but they're all very low. And the tissue damage is, the non-target embolization. The bladder and the rectum really have robust blood flow, and so they tolerate non-target embolization very well. The penis, on the other hand, is not so tolerant of that. So every once in a while, we'll have a patient with a very mild area of temporary kind of skin necrosis at the tip of the penis. It's usually an area about the size of a small coin. And usually it's just like having a scrape on your arm. This requires keeping it clean and dry and putting maybe an antibiotic ointment and just keep taking care of it, and usually heals up within a few weeks. So it's very, very rare that we have anything any more severe than that. And this is all just a bunch of research stuff, which that's just a learning curve that we published for prostate artery embolization. Basically, we found that even from the very beginning, this is my own individual experience, from the very beginning, the contrast that we used and the fluoroscopy time, they dropped after, to 75 cases or so. And the procedure time, of course, drops a lot once you get more facile with it. But we found that when we looked at the amount of beads we injected, that did not change, nor did the symptomatic improvement. So even from the very first case, we had excellent results. So when we're there doing cases in Tanzania, like even though these will be our first few cases, there's still a very high chance that patients will get very, very good results with this. And also the complication rates were very low and uniform even from the very first case all the way out to 300 cases. And this was just a study we just published recently, just showing it that has very low radiation dose, nothing to worry about there. And just some more data kind of demonstrating what a great procedure it is to kind of help address the urologist's kind of concerns about the procedure. And like I said, it just finally got accepted by the AUA, the American Urological Association, about 1.5 years ago into their guidelines. That's not really worth talking about. Future directions, not worth talking about today, but we can go through this more. And lastly, just take home messages here. Who are good candidates? This is the one slide I think I really want you guys to pay attention to. Those who have failed medical or surgical therapy because of or they're just not a surgical candidate because of their gland size being too big or they're too sick. But you can do an embolization on very sick patients and do very well with it. Those with the indwelling catheters, those with the severe hematuria, or patients who can't be on anticoagulation medications because they keep having hematuria. And then sometimes for those patients with prostate cancer, and this is a whole nother talk, but we can shrink the gland prior to radiation if they're going to get radiation therapy, because it will help. If you make the gland smaller, they need much lower doses of radiation, and then that decreases their risk of having complications from the radiation. And then in general, just patients who want something less invasive. And so that's my information, my email. I have a website you can look at. It's switching over to a new website in a week or two. So if it doesn't work, just check back again, because it's just transitioning. And that's my mobile phone in the United States, and you can use that number also to find me on WhatsApp, and I will leave that up there. And I'm just a little bit over. Hopefully that was helpful to you guys.
Thanks, Raj. That's great.
Yeah. I have a
So-
question.
Yeah,
Please.
he immediately, everyone go ahead and ask questions, and also maybe end the call with kind of like a planned timeline. You know, I think basically you guys should start reaching out to urology soon and establishing some connections, and then maybe sort of in the month leading up to Raj's trip, then really start to recruit patients and have them lined up. And of course, you can then plan like some clinics for the first few days when he gets there, and then, you know, line up some procedures. But go ahead, guys.
Fabian, that's already being done. I already spoke to like
Perfect.
2 students, and I'll remind them like a month or two prior to.
Love it. Thanks, Aza.
Yeah, so the first one with that comment, we are a bit concerned because the urologist here locally, they think we are having a conflict of interest, like
Yeah.
we are taking away their clients. So I was wondering what the referring doctors, maybe where does Raj get his clients from? But number
Yeah, that's
two,
always a problem. And again, that whole issue with the guidelines approving it, that was because of that. I mean, everyone knew 10 years ago this procedure was great, and there were enough data, but the urologists would keep roadblocking it because we were, cutting into their business. Well, I think if you show them the data, if you go through a presentation like this and they understand, because some of them may legitimately think, well, I don't know if this works well, or maybe it's too dangerous. One, it's important to kind of eliminate those fears by just showing them, giving them a good presentation. But two, start with the patients that they can't really help. The patients that they're tired of helping. So the patients with gross hematuria, those patients often come back for urgent care or, the emergency departments over and over and over again, because they have a catheter in, the catheter keeps rubbing, keeps bleeding, and the urologist can't offer them anything else because they've tried, and they're quite a headache for those patients are quite a headache for the urologist. So the indwelling catheters, clearly they're not getting anything else, right? Like the urologist kind of gave up on them, and those with severe hematuria, both of those are good places to start.
number two, regarding the last case, you say it's better to embolize both sides, but same catheter position. That I did not understand.
No, and it's not better. In this case, we had to, because the one side, the atherosclerotic plaque had closed up the prostatic artery. And so we were able to salvage the situation. We were lucky that one side did end up supplying flow to both the left and the right half of the prostate. When you do that, it's very rare. Well, I should say the connections across between left and right are very common. However, it's very rare, I think, that you can get a successful embolization of both halves of the gland from one side. But sometimes that's your only option, even if it's not going to be completely successful. And also, I think the risk of complications of non-target embolization goes up, just because the normal flow to the penis is not, possibly not there. And so some collaterals may be supplying a lot of the penis. But no, it's more just kind of like we do it when we can't do something else. And lots of times, again, there will be some connections anyway, so you'll see that just with the anatomy.
Thank you.
Sure.
I have a question about that same case. You said there was a collateral supplying the penis. I'm wondering, how did you prevent any embolic material from going down to it?
Well, we actually didn't do a good job in that case. I didn't mention it. He was the guy who had that area of non-target embolization on the tip of the penis. we couldn't, we did not, because of his atherosclerotic disease, we did not see flow to the penis from anywhere else. And so we left it alone and just tried very carefully to inject the beads very slowly, very gradually to try and prevent things from going down there. And usually that you'll see that in the majority, and Fabian can also attest this, majority of cases, those connections will be there and you have to be very careful. However, in some cases, you just can't avoid them at all. Most cases you can put coils in here or there, but in his case we couldn't, and so you had to be careful.
All right, thanks.
Yep.
Hello, I have a question. What do you do with patients? For example, you got a 75-year-old patient with all possible cardiovascular risk factor, diabetic, smokers. He had already had a aortic coronary bypass. He has an erectile dysfunction for long years. So in those cases, don't you do any CTA upfront?
I think it depends on your comfort level with pelvic angiography. Obviously, yes, that'll be, it can be very helpful to kind of map out the anatomy beforehand. I found with lots of elderly men to ask them to come for an additional appointment beforehand to get the scan done. They maybe didn't have insurance, they didn't want to pay for it, or just they're very elderly, they're in a wheelchair, transportation is a problem. Also, they may have more kind of marginal, kidney function, and giving them that extra contrast load might be concerning. And so once I got more comfortable with the procedure, I realized that getting that pre-procedure CT scan was not really changing my management at all. I found that, I was almost always going to be able to find the arteries and get into them anyway. And so having the scan beforehand didn't really change that. And there are always a few patients that you get surprised, and even though you can see the vessel nicely, you can't get into it. Again, having the CTA may not really change that either. But there's a lot of difference of opinion on that. And I think especially when you're starting out doing these cases, it's very helpful to have that scan if it's easy enough, convenient enough to get. But I found it was challenging to get my patients to get that scan done.
Okay, and I think another group of patients which can be technically very difficult is those who have really elongated iliac arteries, and the typical patients who have also infra-aortic aortic aneurysm.
Yeah.
Well,
you can always do bilateral femoral access if you need to, just so you don't have to deal with going over the bifurcation. Those are good patients for radial access too, if you guys get facile with that. But again, once if you've done pelvic angiography, you can kind of get used to that challenge. And also it's nice to have certain kind of specialty vascular sheaths, longer curved sheaths, so you can, once you get up and over, you can keep the sheath up and over so you maintain a more secure access. I don't know if you guys have those, but those are very helpful for certain cases.
Thank you.
Yeah. Okay, well, sounds like that maybe was it. So I look forward to meeting you guys. I'm excited about the trip. It'll be a good time. So yeah, take down my contact information, email me, call me, or WhatsApp, and we should touch base again. I can give this presentation to you and you can show it to urologists, try and, just kind of get through to them and say, hey, or maybe, like I said, if we can even set up another talk, I can talk to them as well. And kind of go through everything with them as well and answer their questions. And that may be very helpful to generate more cases as well. Because that's what I found when I'd never done one of these, and I gave a talk to the urology group where we were at Yale. And then at the end of the talk, as I was walking out, one urologist came and gave me a referral. And that guy actually, he was one of the patients I presented, the retention patient. He did very, very well. And that just kind of opened up the gates, the referrals started coming in after that. So, okay.
Thank you.
Okay,
All right.
thank
Thank
you.
you. I have to go get to work. So again, it's nice to meet you guys, and we'll talk again soon. Okay.
Thank you.
Thank
All
you.
right. Bye-bye.